I think the most significant development currently in the clinical management of patients and the diagnostic application really is in personalised medicine. So traditionally, we've always considered a patient and their tumour to try to categorise them or assign them a particular subgroup. And I think what we're beginning to realise is that each patient and their tumour is individual and it is unique, and we've learnt that really from the genomic data that has been generated. And I think what we're working towards now is giving individual patients more personalised treatment for their individual tumour, and I think therefore that will improve the outcome. Now, one of the best ways of doing this is looking at the genetics of an individual tumour and comparing it with big data sets and learning from that the genetic abnormalities that are present and the relevance of those, and therefore predicting how patients are going to respond to treatment, because we're beginning to understand that tumours react to treatments in a different way. So really aiming towards true personalised medicine is our current intention, and will hopefully improve the outcome. But I think our most important area is that upfront, more accurately diagnosing the patients and being able to provide prognostic information. And this, for an example for this, is in diffuse large B-cell lymphoma, where we know 75% of patients will be cured with R-CHOP chemotherapy, but 25% will relapse. We're still not very good necessarily at diagnosis, apart from particular subgroups, at actually picking out patients who will have a very good response to R-CHOP chemotherapy and could almost be treated and immediately discharged, or patients that are likely to relapse, or even predicting patients that might relapse promptly or those that might relapse several years later. I think another example is in Hodgkin's lymphoma, so where it's still proving very difficult to predict, even with other techniques such as PET imaging, those patients that will ultimately relapse. So again, the vast majority of patients are cured, 85–90% of them are cured, but 10–15% do ultimately relapse, and we're not able yet from a biopsy at diagnosis to accurately predict who those patients will be. And that has implications for the patients, because many of these are told that they will be cured up front because that is likely, and it can be difficult discussion subsequently if they're then to relapse. And it would be better if we could give them different treatments up front to hopefully cure them, rather than them having to have subsequent treatments at relapse.